So thank you very much for joining us. I'm with Professor Eric Morand from Monash University in Melbourne. It's great to have you here. It's a real pleasure. We've got some exciting things to talk about. First of all, I'd like to talk about the LLDAS study that you were doing in new lupus, or newly diagnosed lupus. So for any of our viewers that may not be so familiar, can you briefly tell us a little bit about what lupus low disease activity state is?
Sure, Chris. It's a pleasure to talk to you today. So we're all familiar with treat-to-target agendas in rheumatoid arthritis and vascular disease, etc. There's no reason that we shouldn't do the same in lupus. So the starting point to do that is establish a target. Remission, of course, is the absence of disease activity. That's what we want. It's rarely achieved in lupus. So low disease activity could be a more attainable but still valuable treatment destination. So a few years ago we published a definition of low disease activity which has since been validated in multiple cohorts, including in a big prospective multinational study. Most of those validation studies show that attainment of low disease activity, especially for a prolonged period of time, is associated with reduced risk of flare, reduced damage accrual, better health-related quality of life, and in the most recent studies, even protection from mortality. So we think it's basically completely validated as a treat-to-target endpoint. But there's always more work to do, and one of the questions is, most of the cohort studies include all comers, including patients with established disease. The possibility that that skews the data in favour of low disease activity state is there. So to try to circumvent that, we've done a study that we presented here at the meeting on patients with recent onset disease.
And what did you find when you applied that to that cohort of patients?
Yeah, so we used our Asia Pacific Lupus Collaboration cohort, which is currently 4,106 patients and 44,000 visits of data. So we can pick an inception cutoff of 1 year since diagnosis, and we looked at those patients compared to patients with longer duration. So first we found that the new onset patients were sicker, had higher SLEDAI, higher use of steroids, more of them were flaring, and fewer of them were in low disease activity. But in those patients with new onset disease who attained low disease activity, there was still good protection from adverse outcome of flare. There wasn't the ability to show a statistically significant protection from damage accrual, but the rate of damage accrual in patients with recent onset lupus is low, and only 13% of that inception cohort had any evidence of damage accrual in the 2.5 years of follow-up. So the hazard ratios favoured low disease activity for damage accrual protection, but there wasn't enough of a signal to show statistically that it was protective. What we intend to do is follow that inception cohort for a longer period, and we would hypothesize that low disease activity attainment would be protective in that group.
Great. Well, thank you very much for answering my questions. I'm sure it'll be useful for everyone at home to look into lupus low disease activity, and certainly something we can use clinically quite easily. So thank you very much.